नमस्कार दोस्तों, वेलकम टू चैनल टॉक्सिकोलॉजी ऑन बोर्ड. Today, this video will be discussing another DABT topic that is regarding chelation therapy. So let's directly dive into the question. This question is taken from ABT recertification question paper year 2009. So the question was, which of the following is not correct regarding chelation therapy? So we need to identify the chelation therapy. What are the different options which are applicable to chelation therapy that you give? See, chelation therapy is something poisoning happens, then in order to treat it in the form of antidote. So what are the treatment? So one of the treatment will be chelation therapy. So that regarding that we'll be reading in this particular concept. So the ideal chelating agent should have relatively low affinity for essential metals. So in our body we need, if you look into the periodic table also, and if you look into metal toxicology chapter also in Placer, no, different metals are there. There are certain metals which are essential, certain metals which are toxic, certain metals which are toxic at low at a higher concentrations, but beneficial at lower concentration. Similar this concept you'll learn in the case of amino acids also. So the first statement is. Question is you have to identify not correct. So the right answer is option B. That is ferritin is clinically useful chelating agent for iron toxicity. Okay, this is not correct. Why it is not correct? We will see. Okay, why means ferritin is a primarily a storage protein for iron. Okay, that is the reason ferritin is clinically useful chelating agent for iron toxicity. No, in the case of iron poisoning, you have to use desferroxamide, not ferritin. Ferritin instead it is a storage protein for iron. Okay. Ferritin, it is been suggested that ferritin may serve as a general metal detoxicant protein because it binds a variety of toxic metals like cadmium, zinc, beryllium, aluminum. Specifically to this particular metal, it is not. It is going to bind cadmium, zinc, beryllium as well as aluminum. At the present time, there is no effective clinical treatment for cadmium intoxication. Okay, and in experimental system, some chelators can reduce acute cadmium induced mortality by chelation therapy for cadmium generally results in significant adverse effects. So with respect to cadmium toxicity also, I have uploaded one video. So previously some questions with respect to cadmium toxicity also they have asked in DABT. I'll give the link in the description. So this is the reason ferritin is not clinically useful chelating agent for iron toxicity. Take home thing what you have to remember is it is a storage protein. Okay. What are the other options we'll see? First option was the ideal chelating agent should have relatively low affinity for essential metals. Relatively low affinity is wrong. Okay, it has to have affinity towards toxic metals, not to the essential metals. And here low word is not right. So we'll see in the next slide. Use of penicillamine, a metal complexing agent, may be clinically associated with hypersensitivity reactions. Yes, there are certain individuals who are sensitive to the penicillamine. So this is the penicillamine which used as a chelating agent. But you have to also, whenever you're reading, try to link it with the penicillamine, beta-lactam antibodies. Different penicillins are there, penicillin G, penicillin B. So there are certain individuals who are highly sensitive to this particular beta-lactam link antibiotics. So that also you have to keep in mind whenever you are reading. So that is the reason use of penicillamine might be causing some hypersensitivity reactions in certain individuals. So that might be not a proper choice for all type of poisonings. Fourth option is chelation therapy in humans to treat cadmium toxicity is difficult because it has been associated with kidney toxicity. Yes, there are certain metals like cadmium is there, platinum is there. They have target organ of kidney. So what they know, they form tubular cast in the kidney. If you check the histopathology of the kidney, tubular cast will be formed. Okay, so those things you have to remember. Cadmium, and there is something related to specific accumulation of cadmium takes place in this kidney cells. Okay, that also you have to read. Last option is British anti-Lewisite. The first clinically useful chelating agent was developed to reduce toxicity from exposure to arsenical war gases. So one concept, one question you have to remember is regarding arsenical. Arsenical means it's a story. It's a like a it's a library of these war gases. During World War One and World War Two, there are a number of chemical warfare agents which were developed. So in order to in order to mitigate this particular poisoning, they developed an antidote. That antidote is British anti-Lewisite. Okay, first clinical usefully chelating agent developed to reduce the toxicity from exposure to arsenical war gases. So we'll read, okay, BAL, antidotes, all those things also I have discussed in my channel. I'll give the link in the description. Today, with the help of picture, all these four options we'll try to read so that we can remember from the exam point of view. So chelation therapy Chelation therapy involves administration of chelating metal binding agent to bind toxic metals in the body to form complexes that can be excreted, thereby reducing metal burden and toxicity. So, as I told you, there may be certain metals essential, certain non-essential, toxic, and certain metals based on the dose. At low dose, beneficial; at high dose, toxicity. So, the ideal chelating agent, what is the characteristic feature of the ideal chelating agent is that the ideal chelating agent should have relatively low affinity for essential metals but high affinity for toxic metals. So, pause the video, read it, try and understand the concept. Okay, then here if you see what is a chelation means, this is a chelating agent, this is a ligand, and this is your metal. That metal can be either lead, it can be arsenic, or it can be cadmium. So this metal will go and bind to this ligand. A complex will be formed, and this complex will be eliminated through excreted through kidney. Here, instead of these are toxic metals, whether it is say lead, arsenic, cadmium, not needed by the body. If it is an essential metal, it should not go and bind to this to this particular chelating agent or ligand. Okay, so excreted through either urine or through bile. So chelating agents form stable complexes with toxic metals that are more water soluble, less toxic, facilitating excretion. So it should be hydrophilic. If a certain this complex is ligand complex, it has to go excreted through kidney means it should not be lipophilic. It should be hydrophilic. Then only it can excrete through either urine or through bile from the kidney. This is the first option that we have discussed. Second option is penicillamine related allergic reaction. So second option was use of penicillamine, a metal complexing agent may be clinically associated with hypersensitivity reactions. So whenever you are reading, read this with respect to beta-lactam antibiotics. Okay. So what is a penicillamine is a thiol containing. Why thiol means SH group is there. Metal complexing agent used for treatment of heavy metal toxicity. So what are the different metals that you remember? Lead, arsenic, cadmium. Okay. Example copper in the case of Wilson disease, lead and mercury. So these are the toxic heavy metals. Okay. So this can be used for copper in the case of Wilson disease also. Try to read about Wilson disease. So that question they will definitely ask you regarding. So which are the following is for Wilson disease? They'll give you the metal, copper, arsenic, lead, like that. You have to remember. The answer will be copper. Okay. Next, hypersensitivity reactions. What we can see with respect to penicillamine is skin rash, urticaria, fever, proteinuria, that is nephrotic syndrome, bone marrow suppression, lupus-like syndrome. So this was regarding second option. Now we'll read about the third option. Third option is related to something related to cadmium toxicity. Okay, Wilson disease, copper. Now we are discussing cadmium. Cadmium target organ is kidney. Kidney, how it is going to affect tubular crust formation, all those things we'll see. Cadmium accumulates in the kidney, causes renal tubular damage, that is proteinuria, glucosuria, renal dysfunction, osteomalacia. Chelation, so our option, third option was what? Chelation therapy in humans to treat cadmium toxicity is difficult. Why it is challenging? If there is a cadmium toxicity, why we can't, a physician cannot go for chelation therapy is that it has been associated with kidney toxicity. Okay, so this particular thing is going to cause kidney toxicity. So why difficult? This cadmium has very long biological half-life, that is 10 to 30 years. This is very, very important. So whenever we are discussing about half-life, no biological half-life, whether certain chemical is going and binding to the adipose tissue, in the case of, for example, in the case of DDT, or there are certain radioactive materials whose half-life is around up to 1,000 years. So these are the another practical challenges when you're going for the treatment. So cadmium in this case it is having very long biological half-life, that is around 10 to 30 years. Okay. Second one is chelators may be mobilized cadmium but can worsen kidney damage. Even though a complex might be, if you are using, there is a cadmium poisoning, you are using a chelating agent, complex formed, ligand is formed. But the what are the, if you see the risk benefit ratio when you say, if you go for such kind of treatment, instead of, you might save the patient from the particular poisoning, cadmium poisoning, but you might put the patient at the risk for kidney toxicity. So that is another big challenge there. So that's why choice of treatment the physician will do based on the availability option treatment options available. Third one is risk of further loss of essential metals and imbalance. Okay. And last option is limited, last point is limited proven clinical benefit. As I told you, you have to check for the clinical benefit ratio also. If there is another option available for cadmium intoxication, you can go. But as we have seen in the previous slide, no, as such, as of today, we do not have a proper antidote, fixed antidote for this cadmium poisoning. Okay. Cadmium in the body, chelation EDTA and DMSA are the drug of choice for the cadmium toxicity, you can go for this type of chelating agent, that is EDTA, calcium EDTA or DMSA, that is your succimer. Okay, excretion through urine or through kidney. Risk may cause or worsen the kidney toxicity. So that was regarding the option 3. Now we'll discuss about there was another option with respect to British anti-Lewisite. So what was the option is? Option is British anti-Lewisite, that is BAL. A common name is BAL. And it was the first clinically useful chelating agent, was developed during World War One to reduce the toxicity from exposure to arsenical war gases. Okay, so another name is Lewisite. Okay, so as I told you, during World War One and World War Two, there were a number of gases, this chemical warfare agents like that of chlorine gas, like that of phosgene. Uh, these were Agent Orange. Such kind of gases, arsenical gases were there during World War One and Two. To in order to treat the patients, the antidote developed was British anti-Lewisite. Okay, so the key point that you have to remember, which is acting as a chelating agent. So this BAL, no, it will bind this invalent arsenic, okay, trivalent arsenic forming stable complexes. So whenever there is arsenic poisoning is there, you are using British anti-Lewisite, it will form complex. Okay, administration by deep, that is intramuscular injection, route of administration, reduced arsenic toxicity and improved survival, paved the way for the modern chelation therapy. So this was about regarding British anti-Lewisite. One more thing that we can remember, the list of antidotes for different type of poisoning, metal poisoning. So first one is chelating agent. What are the different targets? What are the main uses and route of administration and notes? So first one is EDTA, and EDTA you will have different salts are there. Calcium EDTA will be there, sodium EDTA will be there. So what are the metals to which it can metal poisoning for which it can be used is lead poisoning, iron poisoning, cadmium, magnesium, and calcium. So lead poisoning and hypercalcemia. The route of administration that you have to give is parenteral, that is IV. Not effective for other type of this listed arsenic and mercury poisoning. You cannot, it is not a choice. Okay, treatment choice. EDTA. Second one is DMSA, that is succimer. Succimer, if you see, it can be used for lead poisoning, mercury, as well as cadmium poisoning. Lead, mercury, and cadmium toxicity. Route of administration is oral route. Okay, preferred in the case of children for lead poisoning. So in the case of children, you will be see there are a lot of toys which contain lead containing toys or paint strippers. So earlier they used to use the in the case of home, no houses, no paint, old type of houses where lead containing paints were there, and children used to strip off that paint and consume. Oral consumption will be there. Okay, oral exposure will be there. So lot of in such kind of lead poisoning also you can also go for DMS, that is succimer, as a chelating agent for the treatment of this lead poisoning. Okay. Next one, in the case third is DMPS, that is dimer sulfonate. You can pause the video and see. We'll discuss only dimer that is BAL. Okay. So BAL can be used in the case of arsenic poisoning, mercury poisoning, as well as gold poisoning. Okay. Route of administration is intramuscular. Here also we have seen no route of administration is intramuscular, and first effective chelating agent in many cases. Okay. So this was the first developed antidote for this chelation type of therapy. Penicillamine we have discussed. Wilson disease, lead and mercury. The treatment of choice is penicillamine. Okay. There is a risk for causing hypersensitivity reaction. Okay. So what we can remember with respect to from this particular concept is that chelation works by binding toxic metals and enhancing excretion. So it should not bind to essential metal. Whatever the chelating agent which you are using, it has to have higher affinity towards the toxic element, and it has to make it water soluble, and it has to be excreted to kidney. This is the thing you have to remember. Second one is the ideal chelator has high affinity for toxic metal, low affinity for essential metals, that we have seen. Penicillamine may cause hypersensitivity reaction because of the beta-lactam ring we have to remember. Certain individuals are sensitive to this particular class of chemicals. Then chelation for cadmium toxicity is limited by risk of renal toxicity and limited benefit. So you have to check for the risk-benefit ratio. Last one is BAL, that is British anti-Lewisite, was the first clinically used chelator developed to counteract this arsenical war gases. Okay, so hope from this video you were able to learn about chelation therapy, different types of antidotes. Okay, few questions they will definitely ask. Read about Wilson disease also, copper associated. Okay, and kidney. Read about platinum also. How platinum is causing kidney toxicity. That also. Which part of the kidney, whether it is proximal converted to tubule, distal converted, which part of the cells they are going to cause the tubular cast formation will be there, no? That you have to remember. Thank you so much. Be curious. All the best for your exam.